We move on now to Jennifer Doliner, who is our nurse coordinator, our RN nurse coordinator. It's a good lesson to us in that you really don't know what you're missing until you get it. She joined us 5 years ago and has been a crucial link in our team to be able to provide care to patients and have constant contact with a clinician at the phone 5 days a week, 8 hours a day, which she does with grace and the love of patients. But she also has become a quasi-expert in insurance issues that our patients confront all the time. And we gave her the tough topic of healthcare reform at something that sounded better earlier last year as a topic. But Jennifer, can you give us a little bit of your wisdom on the importance of care coordination and successful management of adults with congenital heart disease? This is forward and back and back. There you go.
Okay. So I thought I would start out explaining a little about what a nurse coordinator at an adult congenital heart disease center does. So the short answer is I do many things, some big, some small. But the longer answer is I think the most important thing I do is patient care, and that's both clinical case management as well as telephone triage. It could be anything from helping a patient with an emergent issue, or it could be giving advice for cold symptom relief or a bug bite. But I'm the person, and I'm a nurse on the other end of the phone. And I know most of our patients, so I think it's very reassuring to be able to call a nurse, as Pam said, and the nurse knows you, and you don't have to go through your whole story again each time you call. So I also do, I follow up with lab results, symptoms, test results. I help coordinate care, within UCLA for the patients and outside of UCLA. And I also have, administrative duties such as filling out forms, providing patient letters, working with Medi-Cal, which is California's Medicaid program, and that's been, very challenging. And, I'm also a squeaky wheel. I have to be, and I teach patients to be very persistent. It helps that I'm widely known as a nag in my personal life, so I'm good at this part of my job. Okay, and for more information, excellent information about the roles and responsibilities of a nurse coordinator, I've included this article, and it's on the slide in your, that you can access. So to talk about Medi-Cal, and that is our, that's our Medicaid in California. So the way it works is patients have Medi-Cal, right? And they're either in straight Medi-Cal, and UCLA takes that, and a lot of providers and hospitals take it, or they can be put in a Medi-Cal HMO. And that's pretty much standard across California now. In the last 5 years, it's become the overwhelming way that patients are put into Medi-Cal. So if they have straight Medi-Cal, they can just come here, and they can go to a lot of hospitals. They don't have to stay within a plan, it's just Medi-Cal. But the problem comes with the Medi-Cal HMOs, and I'm just using Los Angeles. Each county has their own Medi-Cal HMO. So what in Los Angeles County, if they're a current UCLA patient, we're already seeing them, and they get switched or put into a Medi-Cal HMO in LA County, okay, we can tell them you pick Healthcare LA, either HealthNet or LA Care, and you're going to continue to see us, no problem. But if it's a new patient coming to UCLA and they have a Medi-Cal HMO, it's not so easy, especially if they're coming from another county, so let's say Orange County. I'll use an example that we had, and it was a patient in Orange County that needed a tricuspid valve replacement, very sick, and Dr. Lynn had seen him in Orange County. So he had Cal Optima, which is Orange County's Medi-Cal, and Cal Optima is not contracted with UCLA. He did have family members in Los Angeles County that he was, he was partially staying with anyway. So he was able to move to Los Angeles County and get Los Angeles County Medi-Cal. From there, we told him to pick LA Care and LA Care Health Plan. And then he had to see a new primary in his health plan. So Dr. Lin wrote a detailed, very compelling letter making the case for why he needed his surgery here, and he had all his medical records. He saw the primary referred him to the in-network cardiologist, and the in-network cardiologist saw his records, saw the letter, and referred him here for surgery. It took about 6 months. And the patient was a really good advocate for himself, and that helps. And I try to teach our patients to be able to advocate for themselves. With the Obamacare Affordable Care Act plans, a lot of our patients now have insurance, where before they didn't have insurance. Or sometimes they were able to afford the pre-existing health insurance plans that were really expensive. But now with the expansion of Medi-Cal and the access to other plans, it's worked out really well for a lot of our patients. But even with private insurance, I really tell our patients, okay, if you're not getting your needs met, okay, go through the complaint process with your insurance company. Okay, you're not getting your needs met still, go to the state of California, and they have a complaint process called an IMR, Independent Medical Review, you fill out online. And our patients who've done that have had a lot of success, even getting surgery approved out of state. But it takes a patient or a family member to be really involved in the process. And unfortunately, some of our patients don't have the support and aren't able to advocate for themselves. And I try, and our other staff try to help them as much as we can. So the future of healthcare. Our patients are really worried about what's going to happen. And, I try to be reassuring. The reality is that many of our patients could lose their Medi-Cal. If pre-existing conditions get eliminated, a huge portion of our patients are going to be left without insurance. We're here to support them and be a resource, and that's it.
Thank you.